The procedure we'll be discussing today and reviewing will be the replacement of tooth number 8, which is a failed endodontically treated tooth. It'll be atraumatic tooth removal, flapless implant placement, flapless bone grafting, and immediate provisionalization of tooth number 8. As you can see from the clinical photo, the requirements for aesthetics are extremely high, and we will be preserving all of soft tissue architecture that we can. Additionally, we are going to try to preserve the buccal plate from our extraction and place the implant atraumatically, and then reconstruct the tissue and bone at the same time using our temp stent provisional to sculpt and mold tissue contours throughout the healing phase. Reviewing the radiograph, we can see the requirements that are going to be necessary from our treatment for the implant placement. And we have a good lateral bone and above the anterior aspect of the implant. We'll be securing our fixture to give it some initial stabilization. Following our guidelines for the atraumatic extraction technique, we will use our Petrangero elevators and forceps to remove the tooth atraumatically, preserving soft tissue contours, causing no damage to the soft tissue, so that we can preserve our contours and have our temporary sculpt that tissue through initial healing phase. And at this point, we see that we have preserved all of our soft tissue architecture. After our manual curettage to the area and rotary instrument debridement to the area, and place a temp stent into the site so that we can start to formulate our ideas and opinions about where our implant should be placed, angulation, depth of implant placement. And this is our guide that we will use, also will be our temporary that we will use when we retrofit back to our abutment. So what I'm measuring now is just showing me that I have 3 millimeters from the soft tissue to the facial crest of the natural tooth, the contralateral tooth, tooth number 9. And on the adjacent tooth at number 8, what we were just inspecting is that there's also a 3 millimeter measurement from that facial height of contour to the crest of bone. This is very important because as we start to discuss placement of the depth of the collar, we are going to follow the line drawn from the facial height of contour of the natural contralateral tooth we're replacing, and then that will be the position where we replace the top of our implant collar or slightly below that crest of bone, depending on variables of tissue biotype, emergence profile requirements, and then also the contour of the buccal plate. So as we've evaluated the depth of tissue height contours now, we know our depth of placement. We have cored our site. Now we will be applying platelet-rich plasma into the osteotomy site prior to implant placement to help us with the stimulation of the healing of the soft tissue and bone around the implant. And that precedes implant placement. The implant we'll be using is a 4.7 millimeter by 16 millimeter in length tapered screw vent from Zimmer. Implant is removed from its vial. Coating of the implant surface with platelet-rich plasma, and then insertion of the implant into the osteotomy site. Slow speed, non-water irrigation. What we usually will do is stop the implant placement just short of its final position, and then we remove the carrier, go to the ratchet wrench, and the final position of the collar is then done manually based on our measurements that we made prior to placement of the implant fixture based off the contralateral tooth readings. Depth of collar placement now is being finalized in addition to in relation, I should say, to the facial height of contour of the bone. And as we discuss in our classes that we do here at the Institute, the collar itself is subcrestal, mesially, distally, buccally, and palatally, but supracrestal within the depth of the extraction socket. Thus, the temporary acting to support the tissue, provide space maintenance for the grafting material, and allow for the soft tissue, the keratinized soft tissue, to migrate along the side of the provisional, hence forming a nice seal to the collar of the implant itself. And we're just confirming our readings that the collar is at or slightly apical to the facial height of contour of the buccal plate. Prior to retrofitting of the temp stent, we will first try in our HLPT4 provisional abutment from Zimmer. We will check our occlusion, and from this we get parameters of how much preparation we have to do to the abutment out of the mouth. And this will be what we'll be retrofitting back after preparation is done to the temp stent. So we'll have to shave from the facial and palatal, and then occlusally we'll have to take the temporary abutment more in the apical position. Prior to preparation of the abutment, we will replace our cover screw over the implant so that we can complete our grafting procedures prior to retrofitting of the temporary. And by placing the cover screw, we will then prevent any graft material to get into the internal aspect of the implant. Grafting complex will be a combination of platelet-rich plasma enhanced Puros grafting material, the 1 to 2 millimeter particle size cancellous chips. And the graft substrate is then constructed. Prior to placement of the graft, we will put an application of platelet-rich plasma between the implant surface itself and buccal plate. And then we will go in with our grafting material, the Puros. We first place into the pouch that we created prior to implant placement, and then go to our modified GAR elevator, which will be part of the Petrongaro elevation and extraction and grafting kit. And this gets condensed between the buccal surface of the implant and the buccal plate. And as we talk in our courses up here on immediate restoration, what is done prior to implant coring is we use our Petrongaro elevator to elevate the buccal plate from the periosteum and evaluate where the portion of our buccal plate is. And as we graft at this particular point, we are then placing the grafting material between the implant surface and buccal plate and then tissue flap. So a two-level condensation to help hold the tissue's contours properly, and the provisional can then aid in that by maintaining space. And this condensation is heavy to the point where we can't pack any more grafting material. And you can see from condensation, we're now putting it into that second level between the buccal plate and the tissue itself. And you can see the little plumping out of the buccal portion that creates. Now, it's very important to remember biotypes of tissue, thin versus thick. This patient has a very thick biotype tissue, which will easily allow for this type of procedure to be done. In the more thin biotype of tissue, you have to be careful not to tear the buccal tissue. Sometimes grafting might be necessary prior to doing that. And now I'm just going to a blunt instrument to do the further condensation of the crustal portion. And you can see just how much grafting material we can get into this pouch to reconstruct that buccal plate to the proper surface that it needs for long-term stability and support. And you can see from the occlusal aspect just how much grafting material is placed between the implant surface and the buccal tissue, hence really reconstructing the entire buccal portion in parameters around 360 degrees of the implant itself. Screw proceeds. Placement of the prepared provisional abutment. This abutment was prepared chair side to appropriate dimensions. The abutment is then secured back over the implant surface itself, and the cover screw is hand tightened. After removal of the wings of the temp stent and the placement of some bonding agent in the provisional itself, we will try the temp stent on and off the provisional abutment to confirm our preparation. Place cotton pellet into the internal aspect of the temporary abutment itself so composite doesn't get into this area. You can confirming once again preparation of the abutment itself, and then some ferment over the access opening, just once again further prevention of composite getting into that screw access opening for retrievability. And then continue trying the temporary on and off. Lubricant applied to the abutment itself so that the composite will not bond once the temporary is retrofitted back. An index placed, which was taken prior to tooth removal, which will align the contact points and emergence profile of the provisional up with the adjacent teeth. So prior to placement of this registration material, our temp stent is put into the incisal edge of that and then inserted into the mouth. Light curing to register the position of the temporary on the abutment itself, and you can see the initial light curing is then followed by a second light curing for further hardening of the composite material. Checking of the occlusion now, as this is an immediate non-functional restoration, free of occlusion in centric relation and protrusive. Any reduction to the incisal edge or to the lingual aspect of the tooth itself would be accomplished at this point. And using our 3M discs to shorten the incisal edges and eliminate any protrusive contacts is accomplished prior to us retrofitting the margins of the temporary. Abutment is removed. It is then placed on an analog, the temporary placed back on, and then we retrofit back the margins with flowable composite. What we also did is we made a second temporary with the patient's natural existing tooth that was removed. So we used our temp stent for one temporary, and showing the fact that we can make it either way. And then also with the index itself that we took prior to tooth removal, we have our second provisional, which is the one we will use, which is her existing tooth shell that was prepared in the same fashion, hollowed out, and retrofitting the margins back. And once again, placing the cotton ball and some ferment so that we don't get any cement or anything into the access chamber of the provisional abutment. And then the patient's natural tooth that we had removed, it will serve as our provisional abutment that we've retrofitted back to the temporary margin itself. Evaluation of protrusive relationships, free of contact in this region. Further manipulation to the incisal edge. And we're just doing some more recontouring of the facial aspect and emergence profile of this provisional abutment to aid in temporary aesthetics. Stop. And what you'll see now in a still photo is the immediate post-operative clinical view and case complete periapical radiograph.